Okay, so the case is about a 70-year-old female who presented with severe hypercalcemia. And this case I'm presenting basically focuses on the management of hypercalcemia. So severe hypercalcemia is defined calcium levels of more than 14 milligrams per deciliter, at which point patients start experiencing symptoms like and it is prevalent in 20 to 30% of malignancies, impacting both solid and blood-related cancers such as myeloma, breast cancer, lung cancer, non-Hodgkin lymphoma. And hypercalcemia that occurs in malignancies it is due to multiple mechanisms, and one of them being the release of parathyroid hormone-related hormone, releasing peptide. And this leads to osteoclast activation and worsening of hypercalcemia. So here we present a case of a 70-year-old female with unknown past medical history. She was brought into the hospital by her daughter with the complaints of altered mental status. Per the patient's daughter, her mother was experiencing weakness for approximately 2 weeks. In the ER, she was found to be febrile, tachycardic, and hypertensive. She was saturating 94% on room air at that time. And her labs were suggestive of a normal CBC, but her CMP revealed elevated creatinine, elevated AST, ALT, and lactic acidosis. She was also noted to have hypercalcemia. Patient was given she was septic. She was admitted to the hospital, and she was started on broad-spectrum IV fluids and broad-spectrum antibiotics and IV fluids. And her serum calcium was consistently elevated despite she received IV fluids. So then she was given 1 dose of zoledronic acid, 4 milligrams. Her calcium did not improve, and calcitonin treatment was initiated. During the 24 hours, the patient's clinical status continued to worsen, and she became febrile. Her lactic acidosis continued to worsen, and then on the floor, a rapid response was called, and she was admitted to the ICU. Her CTA of the chest was performed, given she was hypoxic, and she was found to have a pulmonary embolism and bilateral lower extremity DVTs. So despite all the appropriate therapy, patient's calcium continued to worsen. And then after receiving 48-hour course of calcitonin, her calcium levels started to improve, but her renal function continued to worsen. And her lactic acidosis was worsened up to the level of 29.8 millimoles per liter. And she was then started on CRT, and her calcium levels stabilized the next day to 10 to 11. At one point, there were also discussions about starting her with corticosteroids, where calcium levels improved before that. So the management of hypercalcemia basically involves a multifaceted approach, targeting both acute symptoms and underlying causes. In our case, the underlying condition was malignancy. Hydration, primarily through IV saline, aids in calcium excretion, and medications such as bisphosphonates, calcitonin, or steroids may be used to lower serum calcium levels rapidly and manage the symptoms. Regular monitoring, symptomatic support, and a multidisciplinary approach involving specialists when necessary are crucial for management and prevention of recurrence. And tailoring the strategy of the treatment to each individual patient's condition is needed and fundamental and to address the hypercalcemia effectively.